All right, let's start. Well, hello, everybody, and welcome to the fifth session of LEJENDO, the virtual online endometriosis journal club from the Lister London group. If you haven't seen any of the previous sessions, LEJENDO is an idea of ours with the aim to make journal clubs less boring, if you like. So what we're going to do in each session, which runs on the 6th of every month at 6 p.m. London time, is to present around 6 papers that we found interesting in a very, very short format. And in addition to that, we invite the authors of 2 other papers that we found particularly interesting, usually from papers that have been published in the last year or two, to come and present their own work. So far, we've had very good feedback, and we intend to go on for at least another 6 or 7 months and then reassess and take feedback from all of you. I know that a lot of you will access these offline when it goes on our YouTube channel, which is fine, but we really would like to have as many of you as possible live so that you can ask your questions. We should thank Carl Storz UK, who has been very helpful in organizing these meetings and in promoting them. We have no conflict of interest. We don't receive any payments from any company for these, or at least no conflict of interest relevant to the subject of today's session. So we have the LEJENDO team, the legends, if you like. Avril Bacci, who's my current fellow, is in Rome, attending Gynae Italy. I'll be joining them tomorrow. Kyle Flesher is in London. He'll be starting with me from October. Ben was my previous fellow, who is also in Rome. And Mikey Adamczyk, who is now my consultant colleague in CIMIC London and also at St. Peter's Hospital. And today we have 2 special guests. One is Nucelio Lemos, my friend and colleague, who most of you will know from his great work in the field of neuropelviology in particular. Nucelio, in my opinion, is a very, very rare find. He has it all, really. You know, not only he's a great surgeon, he's an amazing educator, and he produces very high quality research. He has done a lot of work, in my opinion, one of 2 people worldwide who have really worked very hard to promote neuropelviology and to expand our understanding on how pelvic nerves work. And today he's going to present a piece of work that I think really is exceptional. You will see. It is something that is very rarely seen in the field of medicine, in my opinion, at least. So the format of the meeting is that we start with 3 papers. Kyle and Ben are going to present those today. And then we'll go to Nucelio, and then we'll present another 2 papers, and then Dr. Hargu is going to join us. I don't think Dr. Hargu is with us yet. She will be joining us from Tehran in Iran. I will introduce her when she's online, or if she can't come online, we have a recording. There are lots of problems and restrictions with internet access in Iran, unfortunately, because of the restrictions on the internet use, for reasons that I'm sure everybody is aware of. Okay, let's make a start. Ben, I think you're first, aren't you?
Yeah.
All right.
Can everyone see?
Yes.
Okay. Yeah. Okay, so the first paper that I'm going to present today is a paper that was published from UK, from the UCLH team, at Sally Dogan and his team, and it looked at the different outcome in terms of pelvic pain following either excision of endometriosis alone or excision of endometriosis and hysterectomy and bilateral salpingo-forectomy at the same time. This is a single center study that was performed between 2009 and 2019. And the symptoms were evaluated preoperatively and then postoperatively at 6, 12, and 24 months. So these are our two groups. The excision alone were 120 patients, and excision with hysterectomy and bilateral salpingo-forectomy were a total of 100 patients. The population was very similar, 40 years and 41 years respectively, and the BMI was slightly different. We had 25 of BMI for excision alone and 28 for hysterectomy. In terms of previous surgery, again, they're fairly similar. We had 78% of patients which had a previous treatment of endometriosis for the excision alone and 88% for excision and hysterectomy. In terms of adenomyosis, which was diagnosed either with an ultrasound scan or an MRI or through histology following hysterectomy, we had 44% of patients with excision alone that were diagnosed with adenomyosis and 57% in the group with the hysterectomy. If we're looking at the symptoms that these two groups had prior to the procedure, we can see that they were pretty similar except these four. In terms of premenstrual pain, non-cyclical pelvic pain, deep dyspareunia, and difficulty empty bladder, the symptoms were slightly higher in the hysterectomy group. If we look at the final result, we have to say that in both groups, the excision alone and hysterectomy, the pain improves in general for both groups, respectively, if a hysterectomy was performed or not. But if we're looking at the non-cyclical pelvic pain in particular, we can see that in the group where hysterectomy was performed, there was a significant improvement of this pelvic pain, and the improvement was of 2 points or more, which show like potentially like a benefit in performing the hysterectomy in this subgroup. If we're looking at the graph, for example, in terms of non-cyclical pelvic pain, you can clearly see that in the hysterectomy group, that is the blue line, there is like a more improvement of the pain in comparison to when the uterus, tube, and ovaries were retained. If we're talking about quality of life, is actually very similar between the two groups. Actually, if you even then take into consideration the adenomyosis, even closer the gap between hysterectomy alone and excision. So the quality of life doesn't change much between the two groups.
But Ben, can I ask, you know, the group that had hysterectomy, they would have had an indication for a hysterectomy, right?
Yes.
So even the ones that didn't have adenomyosis would have had some other reason for hysterectomy, like a fibroid or heavy periods or whatever, right?
The hysterectomy was always like offered in after the discussion with the patient to see if the benefits were outweighing the risks, and you were always taking into consideration the patient choice as well.
Yeah. I guess the devil is in the details. So this is, we should remember, guys, that these small paper presentations are not proper in-depth evaluation of the paper. So it's not a critical appraisal. It is an introduction so that people then go and read the paper. This one, for example, I think there's a lot that we still don't know why were the hysterectomies done. But I think the message is, in a group of patients where hysterectomy is indicated, the symptoms will get better. But I guess the key word is if indicated. Okay. Kai?
Thanks, Ben. So now I'd like to present to you a paper published in Fertility and Sterility from a group from Ancona in Italy. So this is a retrospective cohort study that aimed to evaluate the risk of endometriosis recurrence according to mode of delivery, so either cesarean section versus vaginal birth, in patients who had become pregnant with a live birth after surgery for endometriosis. Endometriosis recurrence was defined as the ultrasound evidence of endometriotic lesions during follow-up associated with the onset of pain. So that would either be severe dysmenorrhea, deep dyspareunia, or chronic pelvic pain. The results of the paper showed that patients with a history of caesarean section following endosurgery have a higher risk of endometriosis recurrence than patients who had had a vaginal birth, with an adjusted hazard ratio of 2.25. The authors suggest that a different follow-up approach may be needed in those patients, as well as avoiding inappropriate indications for caesarean sections.
And our final paper then of our first three ones is looking into urinary tract endometriosis and the recurrence. So there was a paper produced by Andrea Minervini and his group from Florence. It was published in JMIG in 2022. So it was a retrospective review from patients which were affected by urinary tract endometriosis and treated with a surgical excision in a single center between 2016 and 2020. And the main inclusion was histologically confirmed presence of urinary tract endometriosis. So if you're looking at the numbers, they operated on a total of 105 patients. And these patients also had endometriosis in other areas, but I would like to focus on the final part of this table. So in terms of ureteral involvement, there was unilateral in 44% of the cases, and in 6% of the times was bilateral. In terms of bladder involvement, was 52, so 49.5% of the times. What we looked into as well was if these patients were affected by autoimmune disease or not. And in 20% of the times, this patient had some kind of autoimmune condition. In terms of surgical procedure, they performed a partial cystectomy for all the patients where the bladder involvement was found. And when the ureter was involved, reimplantation was done in 24% of the times. Ureterolysis in 15% of the times, end-to-end anastomosis 6.7, and a nephrectomy is 4.7. Nephrectomy was done when there was evidence of significant reduction in the function of the kidney, less than 10-15%, or recurrent sepsis. So when they look at the recurrence with a mean of 39 months, they saw that 30% of patients had recurrence of endometriosis. If I look in particular at the urological recurrence, was in 14 patients, so 13.3% of the times. The mean average of the recurrence of the urological recurrence was actually 12 months. For the treatment of a recurrence, they perform a ureteric implantation in 6 patients, a partial cystectomy in 6 patients, and a nephrectomy in 2 patients. They went then into look where were the independent factors that increase the risk of recurrence of endometriosis, and what they found that the age of the first surgery, especially when it was less than 25 years of age, increased significantly the risk of recurrence with an odd rate of 1.34. And also autoimmune disease, when present, increased the likelihood of having a recurrence of endometriosis of 1.23 odd ratio. What this looks like is protected is postoperative hormonal treatment, especially when taken for a long time, with odd rate of 0.71. This was the end of our first 3 papers.
That's very interesting though, because you know, I don't know what you think, Marcelio. Have you seen in urinary tract endometriosis? Have you seen this kind of recurrence? So they are saying that they had a very high percentage of recurrence after ureteric reimplantation or bladder excision. I don't know. It's interesting.
Yeah, it's weird. They also have a very high percentage of reimplantation and little. So I wonder if that recurrence rate is related to residual parametrial endometriosis, because if you're developing the fourth space of Okabayashi's to go for that final 2-3 centimeters of ureter, you get a better access to the overall parametrium. You do resect everything. That's the most common site of persistence I see after specialists operate on. Our series for parametrial endometriosis show that 70% of patients with persistent parametrial disease had been operated by an endometriosis specialist before. So that's where I would see an explanation for such a high recurrence. But I agree with you.
And also the timing, I think if it's showing that a lot of them within a year had recurrence, I wonder if it's persistence or incomplete excision rather than recurrence.
I agree with you. I tell all my patients that we have a recurrence rate of 10%. And I tell them that's all on me, because that's probably either a piece of endometriosis that I dropped, the flu from my harmonic or whatever, or some implants that were small that I missed. And I do not believe in recurrence. I believe in persistence of disease.
Yeah.
And that's why I'm so aggressive with my surgeries, right? So that's...
Yeah. Okay, well, thank you very much. I think now is the time to bring Nucelio on. So I introduce Nucelio to you all. I've listened to this talk before, I've read it a few times, and I'm still very much looking forward to hearing it, because I think this is something special.
Well, thank you very much. It's a great pleasure to be here. Congratulations on the initiative, guys. It's you guys have such a wonderful group, and you produce such quality work. It's an honor for me to be here. I'm gonna just hide my video panel here so I'm not obstructing your view. And then we're gonna talk about the paper we just published on our 10-year experience with the post-over Alliance procedure. So I have no conflicts of interest, and you can download these slides here if you want. Just follow this QR code, scan your screen, and feel free to download this. So what I'm going to do today is, reflect the introduction of the paper where we review briefly the history of neuromodulation on the treatment of neurogenic urinary tract dysfunction in people with spinal cord injury. We're going to discuss the application of the laparoscopic implantation of neuroprosthesis on the rehabilitation of people with spinal cord injury, and analyze the outcomes of the post-over Alliance procedure in our center. So a little bit of history. Clinically available, the first procedure that was clinically available for spinal cord, for neuromodulation or neurostimulation in people with spinal cord injury was the Brindley procedure. So what Brindley envisioned was a laminectomy of the lumbosacral junction and exposure of the cauda equina, and then implant. They would do a deafferentation of S2, S3, and S4 nerve roots. With that, you would treat the true overactivity associated to spinal cord injury, and then they would put the stimulating electrodes on the efferent nerve roots to promote, and this would be connected to this antenna with an external stimulator, and that would promote micturition, so they wouldn't need catheters, the CIC, the intermittent catheterizing. They could induce bowel movement with this, and in males, you could also induce erection. This procedure is available still today, and it is very good in well-indicated patient. The problem with it is that it is very invasive, and then several other options have been developed. You're all acquainted with the InterStim and then the other percutaneous options for S3 stimulation. There are some groups that try caudal stimulation for for neurogenic bladder urinary dysfunction. So they run in parallel to the bone table and try to stimulate several nerve roots at a time to try to improve the results with neuromodulation for these neurogenic patients. Spinelli developed the percutaneous technique and the tiny lead for pudendal stimulation. And then Ken Peters in the US also shown that pudendal neuromodulation is a better option for neurogenic pelvic floor dysfunction than S3 neuromodulations. So how does this all lead to the Passover-Lyon procedure? So back in the beginning of this century, Passover was developing the laparoscopic neuronavigation technique to reduce basically a nerve sparing. So that's the beginning of laparoscopic nerve sparing surgery. It was being developed in parallel in Japan and here in the Western world by Passover. So from there, he started learning more about endometriosis of the intrapelvic nerves, and then more and more about intrapelvic causes of pudendal neuralgia, right? And at that time, he was in Jena in Germany. Jena was a big, like the referral center of the former Eastern Germany for neurourology. So it was a big spinal cord injury rehabilitation center. And they had there several patients who had failed or had problems and needed their Brindley procedures explanted, Brindley stimulators explanted. But you can imagine after a laminectomy, the mass and the fibrosis that is there. So people would walk by Passover's OR and see that he was dissecting nerves and seeing that in the laparoscope. And then they approach him to try to implant those electrodes from an anterior aspect instead of going posteriorly. And that worked in 6 out of the 8 patients. And the next step is what I'm going to present to you guys today. So that's where it is now, what we call the Passover-Lyon procedure for the rehabilitation of patients with a spinal cord injury. So he went from a maximally invasive to a minimally invasive procedure. Lyon stands for laparoscopic implantation of neuroprosthesis, and it can be used in a myriad of indications. When we use it for spinal cord injury rehabilitation, we call it the Passover-Lyon procedure. Basically, we use laparoscopy to implant electrodes on the nerves. So you see here, we're inserting these electrodes on the Cox canal. So we have 2 poles on the pudendal nerve, 2 other poles here on the sciatic nerve. And this is the final configuration that is used. So the generator is by the umbilicus. From there, 4 electrodes come out, being 1 going to the sciatic and pudendal, the other one going to the right femoral nerve, the third one going to the left femoral nerve, and then the 4th one going to the left pudendal and sciatic nerves. So with the pudendal nerve, we can create pelvic floor muscle exercise protocols that can be used by our physiotherapists, and also create a neuromodulation protocol that improves bladder compliance. With this, we have a reduction of the impact of urinary incontinence on their quality of life, a reduction of the number of weekly incontinence episodes, and we have a reduction on the frequency of bowel incontinence episodes, a reduced time for bowel management in the morning, and improved erection in males. Some males with retrograde ejaculation have their fertility restored by retaking ejaculation, and 70% of our patients, males and females, report an improvement on their genital sensitivity, so more pleasure with sex. So on the motoric point of view, you see she has a remote control here. She presses the button, and then what we see is a contraction. So she's stimulating the femoral nerves, and that causes knee extension. With the sciatic nerve, we actually are interested at the superior gluteal nerve, mostly, not exactly the sciatic nerve, and that will cause deep gluteal muscle contraction, which stabilizes the pelvis. So simulating everything at the same time, we can start doing some orthostatic training. Then they start practicing weight transfer from one side to the other. From there, they start taking a few steps on the parallel bars. Then the next stage of rehabilitation is what we call therapeutic gait training with the walker. So they start using the walker only on within the rehabilitation environment. And then from there, we start doing what we call functional gait, which is when they start introducing the gait generated, the movements generated by the neuromodulators into their activities of daily living. So in this case here, is using it to leave his car and go into his house. Let's see. So he's going to turn on the generator. And there he goes. So as you can see, it's not that people recover a regular gait or anything like that, but their mobility is much improved. So these are some numbers. We use there's a scale that we just validated and we're about to publish the paper. But basically, this is a scale where we have from 0 to 15, where 0 is a patient that is incapable of rolling, even in bed, to change position, to 15, where the patient is able to walk normally, right? So we go with the main landmarks of the main cornerstones of the rehabilitation process, and we see that every single patient. So the colored lines are the individual trajectories, and the thick line is the median trajectory. But you see that every single patient improves their mobility significantly, and that includes patients with cervical and high thoracic lesions. Of course, the lower the lesion, the steeper the curve, but still a lot of improvement on mobility overall. And this is a scale that only assesses gait. So we had only one patient that had a gait that improved after surgery, but all of our other patients were incapable of gait training, so VISCI 0. And this is how much they all improved. So basically, we only had one high thoracic and one cervical patient that, one high thoracic patient that couldn't get into gait training within 12 months. The cervical one started gait training at 12 months here. We have some improvement on spasticity also. So you see the clonus is here. The equipment is off. Then he turns on the baseline, and the clonus goes away. And these are the devices we use. We used to use this Restore from Medtronic, not in the market anymore, with this remote control that would need to be touching the area over the neuromodulator work, and this charger here. And now we're using this more advanced generator with 32 poles instead of 16. So we have a more accurate simulation. You can distribute not only, the other one would have only positive, negative, or neutral. For this, here you can distribute their the percentage of the charge that is going to each pole. The remote control is better because you don't need to, it works up to a meter away from the patient, and that's a very small charger that is used to recharge the neuromodulator. Of course, not everything is perfect. We do have complications. The main problem we have post-operatively is are the electrode displacements. We call it a complete displacement when you cannot simulate the nerve at all, and partial is when you can tweak your adjustments, increase the voltage, and then still get the response. So we had 5 complete complete displacements that needed to be reoperated on a sample of 30 patients, so 1 out of 6, and 2 partial ones that we managed to go around with the reprogramming. We had 1 patient that had it removed due to infection, and 1 patient that had worsening of the neuropathic pain because they had syringomyelia, and they were like, that was progressing. So I'm not really sure that the neuropathic pain had anything to do with the neuromodulator, mostly with the syringomyelia. But anyways, the patient wanted it out. Another data that is not published yet, but this is what we learned, is this. So we stopped offering these procedure to patients who wanted to go back home, and then we made it a must that patients only did the rehabilitation within our center after this procedure. And this is how it changed. So this is the point in time where we moved everybody to 1 single center, where we have the 24 people involved in the rehabilitation, and this is how much the results improved. Okay, so this is how much mobility they gained after 12 months, and so this is a big jump. So our next steps for this are improving our understanding of the neuroimaging of the patients that undergo this procedure. So we're doing these readings and trying to understand how this affects cortical activity, and then from there we're going to start working on developing brain-machine interfaces and dynamic programming to be able to generate more complex movements than what you've seen. So in conclusion, laparoscopy provides minimally invasive access with optimal visualization to virtually all branches of the anterior division of the lumbosacral plexus. And the LION procedure can be used to increase bladder capacity, improve bowel sexual function, improve fertility, improve proprioception and sensitivity, knee and hip extension with overall improved mobility. This is our course in St. Louis. So we still have a few places if you're interested at coming and learning more about pelvic neuroanatomy. Then this is what I had to tell you guys. Thank you very much.
Thank you, Nicelio. That was absolutely amazing. Every time I listen to this, it just amazes me. Nicelio, what are the barriers to getting the regulators to see the benefit of this procedure? Because, you know, spinal cord injury is a huge problem, and you guys have found a solution for this and have tested it and have now published it. Why is it still off-label? What are the barriers? And do you have any optimism that in countries like Canada and the UK we could offer this?
So I think the main barrier is the cost of adding something to the label. So we do not have many surgeons who are able to do this, and they need to be integrated with the rehabilitation team. So I don't think the companies that make the neuromodulators are interested at paying the cost of registering this, because it's a lot of work and a lot of
study, and I don't know who's going to do that, to demonstrate the cost saving in care for these patients, particularly in countries that have a social care. You know, can you imagine if you get a patient to be mobile and to some extent independent, or at least less dependent, how much money it is going to save the healthcare? And therefore that study may then justify that part of the problem. I don't know if I'm making sense.
Yeah, you are making sense, but you're thinking with a physician's mind, not with the commercial mind. This is how, this is all funded in Brazil. Many of these patients are in a private practice there, and their insurance companies fund it because there is evidence towards that. And then the regulation in Brazil and continental Europe is different from the Anglo-Saxonian world, right? So off-label doesn't mean experimental, and the label indications are more because of the foreign registrations of those products, because what they regulate in Brazil, Germany, or France is the production and the adequacy of a device to be surgically implanted in a human being, right? So then once that is there, the indication goes based on evidence and outcomes, and that's it. So the main problem is indeed the Anglo-Saxon regulation system.
Okay, well, thank you very much, Celio. That's very, very nice. If there are any questions, please post them in Q&A. Celio now needs to leave, but he'll be with us listening. I don't know if there will be any burning questions. Maybe he will be able to answer in the end, but don't know, depending on what his schedule is.
I will just turn off my video and I will log in from my cell phone.
Okay, wonderful. Thank you very much, Celio.
Thank you. I'll keep on listening here.
Okay, so Kyle, it's you.
Grand. So Bern, if you
By the way, yes, just don't forget to post your Q&As, and Avril and Mikey are going to address those questions.
So next, I'm going to be talking about this study from JMIG that looks at the true prevalence of diaphragmatic endometriosis and its association with severe endometriosis. So this was published by a group from Bern University in Switzerland. So this unit is a endometriosis referral center, and for the past 20 years, they have tried to collect data prospectively on all of their patients. This study has reviewed this data from their database. So all patients with suspected endo underwent a complete inspection of the diaphragm bilaterally in prone position. Atraumatic grasping forceps were used to push the liver down, and a steep reverse Trendelenburg position was used if needed. And if a sentinel endometriosis nodule was found or diaphragmatic endo was strongly suspected, the liver was mobilized with incision and section of the round and falciform ligament toward its apex. The liver was then pushed to the left if necessary. So they perform a really comprehensive assessment of the diaphragm. The authors compared the demographic and clinical pathologic characteristics of patients with diaphragmatic endo to those without diaphragmatic involvement using different forms of statistical analysis. So the overall prevalence was 4.5% in their cohort of over 1,000 patients who also had pelvic or abdominal endometriosis, which differs from the background prevalence quoted in the literature. Again, perhaps explained by the unit being a referral centre and also their very comprehensive assessment of the diaphragm. So the paper found that patients with diaphragmatic endo were more likely to experience diaphragmatic pain and chest symptoms preoperatively, which can be expected. The right hemidiaphragm was more likely to be affected, but interestingly, there was a higher prevalence of left pelvic endometriosis and ovarian involvement compared to patients without diaphragmatic endo. Additionally, patients with diaphragmatic endo were more likely to have advanced stages of endometriosis, according to the ASRM classification, and a higher rate of infertility. So, practical implications of this paper. The findings could help clinicians identify who may be at higher risk of diaphragmatic involvement and therefore provide appropriate care. Additionally, maybe this highlights how there needs to be maybe a more extensive inspection of the diaphragm during all laparoscopies.
Okay, well, that's really interesting, Kyle. Our own paper just got published today on our technique to deal with diaphragmatic endometriosis, and we do demonstrate how to mobilize the liver. I think again, it's just an introduction to that paper. I think it will be interesting to see in what percentage of those patients they saw endometriosis that is only on the thoracic side of the diaphragm and not on the abdominal side, and whether or not there is any value in adding a thoracoscopy to the mix. But that's a 1 hour lecture in its own. Okay, Kyle, it's you again.
Grant, so this was looking at, this is a single centre study looking at fertility outcomes after surgical management of bowel endometriosis, and is produced by a group from Bordeaux University and its associated hospital. So this study aimed to assess the pregnancy rate after surgical treatment of colorectal endometriosis in patients with an intention to get pregnant. It was conducted between January 2014 and December 2019. The study included patients with the intention to get pregnant who were younger than the age of 43, with or without a history of infertility, who were surgically managed for colorectal endo. The surgical procedure was complete excision of disease, and post-operative pregnancy rate was assessed following the procedure. So clinical pregnancies were defined by the presence of an intrauterine pregnancy with an embryo with cardiac activity. This study found that the pregnancy rate following surgery was high, although almost 78% of patients had unsuccessfully attempted to conceive before surgery. Natural conception occurred for nearly 46% after surgery. And furthermore, 27% had preoperative IVF failure, and among them, nearly 56% got pregnant post-operatively. And in this subgroup, preoperative live birth was only 14.3%, but following surgery was nearly 48%. And within this cohort, and the cohort is small, the presence of adenomyosis did not appear to affect the results. And this is a Kaplan-Meier curve showing their clinical pregnancy rate over time. So this study adds to the body of evidence that surgery can improve fertility outcomes. As said, this is a small study, but there are 2 RCTs ongoing that are looking at first-line surgery versus first-line ART. These are the ENDOFERT and EFFORT studies, and hopefully something we'll be discussing in future meetings.
That's very encouraging, isn't it? And I think good news for many patients who have fertility problems with severe endometriosis as well. We're still being very cautious when advising patients regarding the effect of surgery on fertility, and we always try and paint a less optimistic picture so that we don't give false hope. But as the evidence gathers, I think there is more and more justification to be optimistic. That with good surgery, good excision of endometriosis, complete excision, perhaps the fertility outcomes could be improved. Okay, and the final one is Ben, before we go to Dr. Haqqu.
I think we're gonna move straight with Dr. Haqqu. We didn't remember. Mr.
Oh,
Redwood.
yes, you're right, actually. Yes, we had another paper that Ben was going to present, but we actually thought it would be a good idea to do that as a featured article, as it was particularly interesting. So it's my pleasure to introduce Dr. Amineh Haqqu, who's my very good colleague from Tehran, Iran. I've known Dr. Haqqu for many years now, since the time that I went to Iran to teach. We had 4 fellows that we trained. I didn't have the pleasure to work with Dr. Haqqu at the time, as she was being trained by surgeons better than me, but I have kept in touch. Dr. Haqqu is a very experienced endometriosis surgeon, and it has been a pleasure seeing her work and seeing her development in Iran. Many of you may not know, but the severity and the complexity and the volume of surgery that they deal with is just out of this world. So when I went there in 2013, I was already doing a lot of endometriosis surgery in the UK, but the complexity really surprised me. So I know what kind of operations Dr. Haqqu does, and the paper she's going to present today is the issue that we've always had and will continue to have, which is the balance between, okay, if I do a proper surgery to excise your endometrioma, I'm going to then reduce your ovarian reserve. We in our center have started doing alcohol sclerotherapy, and in fact next month, I think it is, the team in Italy, Dr. Crestani and his colleagues are going to talk about alcohol sclerotherapy with us. Is that right, Ben? Is it next month or? But anyway, yeah, we've been doing that with a hope to minimize the reduction of AMH. Dr. Haqqou's paper is going to show us that actually maybe the reduction in AMH is not necessarily as bad as we have always thought. Dr. Haqqou, the stage is yours. I don't think we can hear you. No. No, unfortunately, we can't hear you. I think your voice is not connected. Let's see. What we will do, I would suggest that you disconnect and connect again. And in the meantime, we're going to start playing your, what I can see. Can you hear me, Dr. Haqqou? Okay, because what I see here on my side is that although you're not muted, but somehow your microphone is not connected. So there may be a problem with the connection of the microphone. What we will do is, while you come back, we will play the video that you kindly sent us, and then hopefully we'll be able to talk to you for the Q&A. Ben, do you want to stream the video?
Yeah, let me know if you can see and hear well.
Yep, we can see.
Ben, I can't hear anything though.
You're gonna start in a second. Here we are.
In the name of God. Increasing trend of serum anti-mullerian hormone level after long-term follow-up of endometrial resection. Dr. Amineh Haqqou. AMH production mechanism. AMH is expressed by granules of cells of growing follicles from the primary up to the small antral stage. In review article, there are many literatures about the negative impact of endometrial resection on AMH. AMH drops significantly when compared with cooperative levels. Negative impact of excision of endometrial reserves. The AMH level decreased and the FSH level increased.
Okay, I can share my screen.
Okay, that's good. Let's do that. Let's stop the video. Yes, go on, Dr. Haku.
Okay. But there is, I'm touching share screen, but it cannot be shared.
Okay, Avril, do you?
Is there any permission for me?
Yeah, let's see. You should have the permission already, but we will just have another look. Because you are a panelist and panelists all have permission to share. Okay.
It's okay now?
No, we can't see anything. Have you shared? Okay, Dr. Akgu, let's see the rest of your video and then we'll talk for the Q&A. Is that okay?
Okay.
Okay.
Is it not
Go.
shared now?
No.
No. Okay.
Okay. It's
Because
good
it
that
was
you
in
sent
new
the.
version.
It's good that you sent the video. So that's a good planning. Thank you for doing that.
Thank you.
Okay then. Oh, we can see now. Is that your screen? No, it's Ben's screen. It's Ben's screen.
Can
Okay,
you see?
go on.
It's my screen. Yeah.
Yeah.
Laparoscopic cystectomy for endometriomas, especially in older patients and those with bilateral cysts. And also we know about the effect of various medicine on AMH level. General cause decline in serum antimullary hormone.
We can't hear, Ben. Ben, we can't hear. You've gone on mute.
Combined oral contraceptives. Is it possible increasing AMH post-surgery? There are some literature in agreement with. Decrease would be only temporary and could recover. Mean 1 year post-operative AMH level are not statistically different from the mean values prior to surgery. Significant decrease AMH level 3 months after cystectomy, but no further fall in the 1 year assessment. Review article. In agreement with our finding, approximately 18% increase in the serum antimullary hormone levels 3 months after surgery in comparison with those 1 month after surgery. Endometrioma doesn't impair the AMH levels, and laparoscopic endometrioma stripping surgery doesn't appear to cause a damage in the serum antimullary hormone levels in the short time follow-up. About method of cystectomy, ultrasonic energy showed a lower impact in post-operative AMH levels comparing with the use of suturing. The same result was achieved in a previous meta-analysis. Entering the non-cleavage line of the cyst, removing excess tissue from the ovary and damaging the cortex, as well as using a cautery or heating device around the ovary for hemostasis or burning endometriosis lesions during cystectomy may decrease AMH level more. Recovery time for AMH. After ovarian injury, compensatory mechanisms may include the recruitment and growth of primordial follicles and the excessive activation of granulocyte cells. The delay in this recovery is explained by the approximate 180-day duration of folliculogenesis from the primordial follicles to the pre-ovulatory follicles. This is our paper, Increasing Trend of Serum Antimullary Hormone after Long-Term Follow-up Endometrioma Resection, that we published in Journal of Endometriosis Pelvic Pain Disorder. Prospective cohort study for 2 years for patients that underwent laparoscopic cystectomy for endometrioma, either unilateral or bilateral. Inclusion criteria: women of reproductive age of 80 to 35, presence of sonographic features of uni or bilateral endometrioma, no history of previous ovarian surgery. Exclusion criteria: presence of tubo-ovarian abscess before or during surgery, ovarian cancer, history of unilateral oophorectomy, history of ovarian surgery, patient with endometrioma who were candidated for hysterectomy. All patients discontinued all anovulation medicines, such as OCPs, 3 months before surgery. Then the initial laboratory test was done. After that, OCPs were prescribed for 3 months after laparoscopy, then discontinued. Serum antimolecular hormone levels were assessed before laparoscopy, 3, 9, and 15 months after surgery. After the initial entry, the pelvic cavity was explored and the surface of the cyst was assessed for possible evidence of malignancy. The ovary was mobilized from any adhesions. The inner wall of the cyst wall checked for possible vegetation. The cleavage plane was identified and stripping was done by applying gentle traction to the ovaries. Complete excision of cyst was done. Pelvic endometriosis implants as well as deep infiltrative endometriosis were removed. Sutures were made for the closure of ovarian parenchyma and bleeding control. We didn't use any cautery or hot energy on ovaries. And this is a video for showing our technique. This is bell pepper technique. We remove the invagination site. As we remove the head of bell pepper, and this is a video of our technique, suspending the uterus, overulysis gently, finding the invagination site, cut around the invagination site with cold scissor. We don't use any cutter or harmonic on cortex. Remove the cyst easily. With this technique, we can remove the cyst easily if we go through the base cleavage plane. Not using any hot energy on the ovary. Suturing the ovary for hemostasis and reconstruction, both. Save the ovarian reserve as much as possible. Try to put most of sutures inside the ovary for preventing adhesions and for better hemostasis. After that, we suspend the ovary temporarily for approaching to deep infiltrative endometriosis. Considering the laterality increasing trend was observable when comparing AMH level of 3 to 9 months and 9 to 15 months after operation, especially in patients with unilateral endometrioma. Mean AMH level was 2.9 AMH levels before surgery. AMH levels decreased significantly 3 months after cystectomy, comparing to preoperative levels to 1.07. Gradually increased up to 15 months after surgery. In addition, the AMH level increased significantly from 3 to 9 months, as well as from 9 to 15 months after surgery, without recovering to the preoperative levels during the follow-up time of the study. However, in 31%, patients' AMH levels at the end of the treatment were higher than before surgery. Regardless of the laterality, all participants with unilateral or bilateral endometrioma decrease in trend of AMH changes before surgery to 3 months after surgery is significant. Conclusion. Although there was a reduction in AMH level 3 months after cystectomy in patients with endometrioma, Then the serum AMH level 9 and 15 months after surgery increase gradually. Therefore, it can be hoped that the AMH level will improve by appropriate surgical techniques several months after the operation. In addition, we didn't prescribe anovulatory medicine after surgery. Therefore, AMH level gradually increased after cystectomy. Thanks for your attention. Stay safe.
Thank you very much. Let's go through a couple of questions that we've had. One for Nuselio. I don't know if Nuselio can hear us.
Yes, I can hear you.
Hi. So Nuselio, Ms. School, Nahid is asking about a patient of hers. Nahid is a colleague of mine in the UK. 53-year-old patient who has a history of fecal incontinence, and the only option given to her is stoma. And she has had pelvic endometriosis. These have been completely excised. Nahid thinks that the etiology is most likely pudendal nerve trauma during difficult childbirth. Do you think she might be a candidate for alliance procedure?
She can, but for fecal incontinence specifically, S3 neuromodulation, so an InterStim, appears to have better results than pudendal.
Oh, okay.
So I would advise a trial of sacral neuromodulation, which is readily available in the UK. So
yes, okay. So that's interesting that this haven't been considered, or maybe has been considered and felt not to be appropriate. I have a question for Dr. Haqqu. First of all, do you consider egg or embryo freezing before surgery for endometriomas? You're mute. Dr. Haqqu, okay?
Yes, okay. Sorry, it was disconnected and I didn't know what you asked me.
Yes, so do you consider fertility preservation, egg or embryo freezing before endometrioma surgery?
Actually, after doing surgery for many patients, I see that the quality of oocyte that we preserve before surgery is not comparable with the ovarian function and the ovarian quality, the ovarian oocyte quality after surgery, when we remove all cytokines and all oxidative around the ovaries. So I only intend to do the ovarian preservation before surgery, especially for patients that their AMH level is very low and the ovarian cortex is very thin. And for other patients, I don't look for the AMH when the cortex is good quality and good thickness, and go straight forward for surgery and try to preserve ovarian tissue as much as possible.
Okay. And Nuselio, what's your practice with endometriomas? What do you do with these difficult patients?
So the main problem we have is the criteria for coverage of oocyte retrieval preoperatively is they're very strict here in Canada. So many patients will not have the resources to undergo that. But basically, I highly recommend whenever we have a bilateral endometriomas, and we offer to the patient a referral to the REIs for that, and every time there is any endometrioma. But most of the patients, unilateral ones, with good reserve, they opt not to because of the costs involved.
Yes, and I was speaking to Dr. Shahnawaz, who is a fertility specialist working with Horace. they have really interesting data. They were saying that, in fact, the patients that do manage to have good quality eggs or embryos retrieved are the patients that will never use those because they will fall pregnant after good surgery. And the ones that have bad quality egg or can't produce any eggs, they are not going to succeed after surgery either. So that was an interesting way of looking at it. I have to say, I'm very optimistic about the alcohol sclerotherapy. So anecdotally, what we have seen, we've started this a year ago, and anecdotally, we've seen really good results. So one patient, in fact, she was from Brazil, we did alcohol sclerotherapy. Then she went to Brazil and had 20 really high quality eggs retrieved, and then very high quality embryos resulted. That is after sclerotherapy. Anyway, this is, in my opinion, even more difficult than nerve endometriosis. Finding the right solution for these patients where you need to balance proper excision with the risk of AMH reduction. Okay, we're close to closing. I just want to share something with you before we go. If you have any further questions, please put them in there. But our endometriosis boot camp, I want to just let everybody know that the registration is now open as of today. So we are going to run, me and Mohammed Mabrouk, we're going to run a very interesting concept in the French Alps next year in January, 20th to 27th of January. And all the people that you see in the screen, Avril and Kyle and Ben and Mikey, they're all going to be there. And basically, it is a very intensive program. We are going to have 6 days of teaching, both early morning and in the evening. And during the day, those who want to go skiing, they go skiing. And those who want to stay will stay with one of the faculty members and watch videos, continue discussing. So basically, by the end of that week, you are going to be sick of endometriosis, I think. But it's going to be very interesting. And the first time we're doing that. Avril, did you say there was a question?
Yep. Yes, we have a question from Christina for Dr. Hagu. Her question was wondering, what was the rationale behind selecting a patient population behind the age of 35? Could your results relate to the better ability of ovarian tissue to regenerate in patients of a younger age? And if so, how do we expect these findings to translate in patients above the age of 35, those who constitute the bulk of patients we see in our fertility clinic?
You're on mute. Doctor,
okay, can I answer?
Yes, yes, please.
Okay, why we chose the 80 to 75-year-old patients? Because we know that the loss of primordial follicles or ovarian reserve has a significant accelerated decrease at about 37 years in most, that is associated with a significant decrease in fecundity. And we know that secretion of AMH starts by the fetal Gernsback cells around the 36th of pregnancy and reach a peak around 25 years of age. So we chose the age between 80 to 35 years because we didn't want to enter the changes that are related to age. And I'm not sure, and I hadn't investigated compare between the patients that are above 35 and below this. We had this opportunity to take the AMH for the patients in this range of age.
Thank you very much. So that's all very encouraging. Maybe it's not all doom and gloom. So we've had some really good news about fertility and endometriosis today. Well, I thank you all for joining. Our next meeting will be the 6th of next month at 6 p.m. UK time. Yes, Dr. Haku, you wanted to say something?
Yes, if there is any time. I wanted to address that what is the main difference between our literature, our paper with other papers. In most literature that I searched, the surgeons didn't discontinue OCPs after the surgery, and they thought that AMH is not dependent on OCP before, but now that it's not dependent, now we know that it is dependent. And if we prescribe OCPs more than, or generous agonist more than 6 months, it will decrease the AMH. And another thing what didn't use any hot energy. And a new thing that we are working on it is cleavage on cleavage plane that I wanted to show you, but I cannot share the my screen because the new things and investigation that we are working, that we do cleavage, find the cleavage plane, and again do traction on the cleavage plane and find the second cleavage plane. And with this type of surgery, we are seeing that the ovarian preservation is much more than better than we did before.
Yeah, but of course, as I'm sure you would agree, not all endometriomas are not the same. Some of them will have a very nice cleavage plane that doesn't bleed. Others will be very sticky. The size of the endometrioma matters, whether or not they have been on GnRH analogs for a long time, you know, have been reoperated on. It's a really difficult one. Again, the group in Bordeaux tend to nowadays favor plasmajet for endometriomas. I'm not convinced. I think excision probably is still the gold standard, but we don't know the answer yet. But I think you're right. The important thing that you demonstrated is not using diathermy if you can avoid it, and try and use sutures to stop any bleeding that you may find, and perhaps do the endometrioma. That would be my advice to my fellow surgeons, that do the endometrioma at the beginning of the operation when you're not tired, because that probably is the most important part of your operation. If you do it at the end of the procedure, where maybe you've been operating for 3 hours and you just want to finish, it's not the right thing to do. I think this is the most important part of the procedure, and therefore needs to be done carefully and patiently. Okay, thank you very much. We're going to close. Thank you for everyone who attended, and thanks to the legends of LEJENDO, Ben, Kyle, Mikey, and Avril. We saw that somebody reposted our LEJENDO with a G instead of a J recently. So we are known by LEJENDO as well. So, you know, maybe endometriosis can grow in legs as well. And special thanks to Dr. Haku, Dr. Lemos, who dedicated their time. They're both very, very busy clinicians. I'm personally indebted to them. Thank you very much, everyone, and have a good evening.
Bye.